our special guest is Dr. Niki Zacharias Millward, and she's a cancer researcher at MD Anderson in Houston. She got her bachelor's in chemistry from Texas A&M and followed with her PhD from CalTech in 2003. She is a faculty member and assistant professor of urology I think that's how you say it, at MD Anderson. Okay, so Dr. Niki, welcome this morning. And I would like to start off by asking you just a few general questions first, if that's all right with you. Is there any truth to the rumors that large pharmaceutical companies want to treat rather than cure cancers?
I would say that's not true. I mean, the issue is that unfortunately cancer is a very heterogeneous disease. So, you know, if you get treatment for your cancer, it'll kill the cells that treatment works on, but the other cells that are not dying, what happens is they, you know, keep proliferating, they keep growing. So quite often, you know, you'll have a response with that drug, but like I said, there'll be cells that don't respond to those drugs, and they keep growing. The other part of the problem with cancers too is the cells can evolve, so the cells can change themselves, so then they stop responding to the drug also. So I mean, you know, it's a big deal in cancer research to find the tumor, to find cancer as early as possible, because that's your best bet at having a full recovery, be cancer-free for the rest of your life. Is to get it early and, you know, to have it surgically removed.
Yes.
So, you know.
Is Big Pharma providing any of the funds for the research that you do?
They do provide funding. They provide more funding. So I'm much more sort of basic research and preclinical research. So really studying the cancer biology and understanding metabolism of cancer and understanding which proteins are involved. A lot of pharmaceuticals, so, you know, my department though, we have a few PhDs, but most everyone here in my department are MDs and are surgeons. So a lot of them do get funding from industry to do certain trials. So we have there's a lot of trials on neoadjuvant therapy. So what that is treating the patient before surgery. So, you know, we now realize that, you know, surgery is sometimes the best thing that can happen, right? That we just remove all the tumor as much as possible. But unfortunately, some patients have larger tumors than others, and that, right, initially the tumor can't be removed by surgery. So we treat them with chemotherapy initially, let the tumor shrink, and then the surgeon comes in and takes up, you know, removes all of the tumor and gets what they call clean margins. So in other words, there's no more tumor anywhere else in the body. And we see really good outcome with that.
Very good. You mentioned that the start is with the chemotherapy. I read so much about immunotherapy being the first step. Is that true for the urological cancers also?
So it depends, but yes. So, you know, my research is really on what they call renal cell carcinoma, which is kidney cancer. And one of the first treatments now that is being done for kidney cancer is immune checkpoint blockade. So is immune therapy. So, you know, we now realize that one of the ways tumors can grow in our body, right, and sort of tell our body not to fight the tumor is to create all of these proteins on the cells of the tumor that tell the immune system to go away, okay, and to turn itself off. So now we have drugs that cover those proteins. So now all of a sudden we can have an immune response to the tumor. And so for kidney cancer, we see in several patients that this works really well. and that they can be on immune therapy prior to surgery. Then they remove the tumor and they see that, the tumor has shrunk. There's lots of necrosis, so a lot of the tumor has died. So, it works very well. Now, we're still trying to understand some tumors and some patients, really respond really well to immune therapy. And they'll have 100% full recovery. But there are some cancers like prostate cancer where immune therapy doesn't seem to work very well. And we're still trying to understand why that is. If there are other cells that are involved and not just the tumor that's sort of shutting down the immune system, can we use other things to sort of turn on the immune system to fight prostate cancer? But like, for instance, prostate cancer is what they call a cold tumor, meaning that immunotherapy doesn't seem to work on it as well.
Thank you for mentioning prostate cancer. Is there anything being done to speed up the basic research and to clinical applications for prostate cancer? It seems so prevalent nowadays.
Definitely there's a lot of research being done at MD Anderson on prostate cancer and a lot of research on trying to understand its progression. But again, it's one of those things like, one of the other things that on prostate cancer, the earlier we can find it, the better. We also realize that, not all prostate cancer is the same. So some patients will have a very indolent form of prostate cancer. So, it will never really grow that large. It won't metastasize. In those patients, we can just keep on what they call active surveillance. So they'll just keep monitoring that person's prostate by imaging or PSA scoring. And then some patients, we know that they have a much more aggressive form of prostate cancer, and sort of deciding which patients have an aggressive form that we need to treat right away versus patients that we can just sort of keep watching and waiting and, looking to see that it stays relatively small. So there's a lot of work in that too. Because, the other thing that we don't want to do is we don't want to over-treat people either. Because of course, a lot of these treatments are hard on the body, right? Yeah. So trying to decide which patients should have treatment and which patients, we can avoid.
And through research and study of the cells, you can tell which of the prostate cancers are the fast growing and which are the slow growing then? And the fast growing is treated?
Relatively. They do a lot of biopsy. So, looking at the tumor tissue itself. So that they can look at and score the tissue, and they score it pretty much on how aggressive it is. And that's how they decide.
Now, with prostate cancer, I was always told that it's a very slow growing cancer and that all men have the cells for prostate cancer if they live to the age of 80 or above. Do you know if there's any truth to that, or has that been disproven?
So definitely age. So cancer is an age-related disease, like in the respect that for most cancers, a major factor in the, you have a higher chance of getting it the older you are. Yes. And so, definitely on prostate cancer, age is important. But that's why, why it's important if someone is, let's say, 90, right, and they just are, been discovered to have prostate cancer, do we treat that patient with really toxic drugs that are, maybe will honestly shorten his life faster than just not treating?
Maybe leaving it alone. Yeah.
So that there's a lot of interest in understanding that, right? And also finding treatments that are easier and more tolerable. We have a huge proton therapy huge proton therapy research building over at MD Anderson. And like proton therapy is one of those treatment options that we're also using for prostate cancer because it has a lot less side effects.
Yes, less side effects than the radiation.
Right.
Is radiation therapy still used with?
Oh yeah, radiation therapy is still used. Even though we've definitely gotten better at it. We've gotten better at just treating the tumor itself and not, the surrounding tissue. We've also, there's lots of different clinical trials on using small molecules with radiation to sort of increase its ability to kill the tumor, but protect the rest of the cells around it. So, but yes, definitely radiation is also still being used.
Of course, prevention would be the best. What is chemo prevention?
Um, so chemo prevention, how I think most people look at it is if you can take something that sort of protects you from getting a cancer. So for instance, a lot of people, will take aspirin, for instance, to, protect them from colorectal cancer. Okay. So like aspirin does seem to have some, effects to protect you from colorectal cancer. And these patients that are taking low dose seem to have less chance of getting colorectal cancer than others. But, they're still trying to do, so those are all, there's sort of retrospective studies, which are studies where we look at patients sort of in the past. And then there's prospective studies where we're looking at, patients and subjects, while they're being treated. And a lot of retrospective studies show that aspirin might help, but a lot of prospective studies don't show the same correlation. So it's very hard to be able to like figure out what drugs will help you prevent cancer. But I know aspirin's being looked at. There's metformin, is another drug that's being looked at. So those are all things that are sort of being, because of course that's what we would all love to do, right? Is that if you could take something that, instead of getting cancer when you're 70, you get cancer when you're 90. I mean, that would be
better. Now, in your research, do you ever use robots?
Robots?
Uh-huh. Or nanobots in your research?
I don't use robots, but the surgeons use robots all the time. Yes. So we have multiple robotic surgical suites that our physicians use. So I think we have like 4 or 5 robotic surgical suites. So, that's a major area that's also being looked at. Instead of doing, open surgery, by using robots, we can make much smaller incisions.
Okay. You mentioned that aspirin might help prevent some colon cancers, and I guess the research is still out on that. But is there any research into treatments to prevent reoccurrences of cancer for those who have already been afflicted?
I think there is, but that's not my area of expertise. I would say that what happens more often is that, the patient is put on after they have surgery and after we say that they are cancer free, that they're put on some kind of regimen that they come in, every 6 months and maybe get an ultrasound or they get blood work done. So they're constantly just, checking on the patient just to make sure that everything still looks okay.
Yes. I know of so many patients who make it through their cancer therapies wonderfully, but then they have that worry that it's going to come back. So I was hoping that there was research into things that would prevent the cancers from recurring. Is there any chance of a vaccine helping prevent cancer in our lifetime?
There are lots of people working on it. I'll tell you that. Lots of people working on it. And in some of those cases, I would say that the vaccine is they're looking a lot more. So there are people, of course, who are genetically predisposed that they have a higher chance, right? Like if they have a BRCA mutation, or there are patients that have it's called VHL disease, where they have a particular mutation in a protein and they have a much higher chance of getting. And we know these sort of
Traits.
genetic traits of these patients that we need to watch. So those patients are put into like a sort of a high monitoring clinic, and they come more often than when normal patients would come to be checked. And I know there's a lot of interest in if we could vaccinate those patients, because we sort of know what's going to drive their disease. So if we can sort of initiate their immune system to go ahead and kill those cells whenever they see them, that's one of the areas that's being looked at. And I know there's a lot of clinical trials that are being looked at for that.
Very good. Can you tell us what markers are and how they're identified and the role they play in cancer research?
So, when we talk about markers, we talk about biomarkers usually. So we're talking about proteins that are elevated because you have cancer. So in prostate cancer, PSA, prostate specific antigen that we're measuring in your blood, that of course gets increased when you have prostate cancer. It's also sometimes, it can also be used to show that treatment is working. So, we'll begin treating the patient. We'll do the PSA before, and then we'll do a PSA later, and we'll see that it goes down. I know in ovarian cancer, they use something similar, like CA-125. They look at, and look to see if it's going down. So that gives us an idea that the treatment is working. We're honestly, there's a lot of research in trying to look at other biomarkers that are maybe more specific to the tumor, like looking at the DNA that's being shed by the tumor in the blood, and then looking to see if we can figure out if there's a particular mutation in that DNA that we can use a targeted therapy just specifically for that cancer. So, there's a lot of work that people are interested in doing, patient targeted therapy, where we know that this patient has this mutation in their tumor, and we have a drug that specifically kills cells only with that mutation, and we're going to go ahead and test it on that patient. So
Dr. Niki, do you ever work with mice in your laboratory?
I work with mice all the time.
You do?
Yes, I do.
Tell us more.
So, I do a lot of research on some rare cancers. So, we have, in kidney cancer, there's a cancer called renal medullary carcinoma. So it unfortunately occurs in very younger patients. And unfortunately, when it does occur, it's a very, we usually catch it after it's metastasized. It's in a very aggressive cancer. We don't have any treatment options. Like it can be treated with chemotherapy, but unfortunately, usually it only responds to the chemotherapy for 3 to 4 months. Oh. So so it's hard because it's so rare. We don't get very many patients with this disease, but like I said, it's extremely deadly. So what we're interested in doing is so we now have genetically modified mice where we can take human cancer tissue, put it directly into the mouse, and the tumor just keeps growing. So it sort of allows us, right, to have a model of this very rare cancer that we can try to understand its biology. We can do treatment studies on it and see what, reduces the tumor. So, I know, so we work with oncologists also. So like I said, I'm in urology. So most of my MDs are surgeons, but literally across the across the hall from us are oncologists. So, we've, based on our mouse studies, we have talked to drug companies and been like, well, we see this great result in the mouse. What do you think about opening a trial with patients? So, I mean, this is sort of a way, especially for these rare cancers, a way to, show that this molecule or this drug might, give them a higher chance of survival.
Now, Dr. Niki, you mentioned the rare cancers and that you do kidney cancer research. Is kidney cancer one of those rare cancers? I've never heard of it before.
Kidney cancer itself is not rare. It's about number 6 in the number of prostate, of course, and breast cancer are above it. But for urological cancers, I think bladder is like the 3rd most common, and then kidney cancer is the 6th most common.
Do you know the risk factors for kidney cancer?
The risk factors are pretty similar to the risk factors for most cancers. So smoking, obesity are the 2 main ones. Also, with smoking, sort of environmental toxins are all risk factors.
How about the age of the patient? Are kidney cancer patients usually an older population?
They usually are. They're usually an older population. But, and a lot of, like I said, a lot of cancers are very heterogeneous. So, it's hard when you say like breast cancer, you say kidney cancer, or even prostate cancer. There's lots of different forms of prostate cancer. There's lots of different forms of kidney cancer, and some of them are much more aggressive than others. And like that's part of our research, is trying to understand that and understand, you can't, if you don't want to treat the disease, you have to treat the disease differently based on what type of, for instance, kidney cancer you have. So there's literally 10 different forms of kidney cancer out there. So like that, it's very important to know exactly what you have. So, I mean, I think more people are more knowledgeable about breast cancer, but like in breast cancer, right, we state, is it estrogen receptor positive, right? Is it still using estrogen for signaling? Or is it estrogen receptor negative? We also sometimes look for HER2, if it's HER2 expressing or not. And these all tells the oncologist what drugs would be good to use on that tumor, which again is either your question about biomarkers comes, with the same idea.
Now, with kidney disease, I think we've all known people who have gone through dialysis. Does dialysis increase the risk of getting kidney cancer?
That's a good question. I don't know that.
Okay.
I don't know the answer to that.
I was wondering about that. Okay. Now, can you tell us what your dissertation was on?
Yeah, sure. So I really switched fields. My dissertation was more on neurobiology. So I did a lot of looking at something called ion channels. So, how our nervous system works, right, is we send electronic signals, through our neurons. And how those electronic signals get pushed from one neuron to another is through a protein called an ion channel. So I did a lot of research on making different substitutions on the ion channel and trying to understand how that affected its function. So that was my PhD. Okay. But it gave me a good background in understanding the overlay between biology and chemistry, and trying to use chemistry to understand biological systems and to be able to probe biological systems.
Organic chemistry through and through. Has your work been affected by COVID?
Yes. So MD Anderson, in March, we had sort of closed down, and all researchers and all what they would call non-essential staff were sent home. And we were sent home from March until about the middle of June. And we did a lot of the surgeries were reduced in number. There was a lot of, just trying to get ourselves up and running and testing. So we have our own testing ability. So, we do our own testing in-house at MD Anderson. So, they were figuring out how to, test all the patients. So all patients now that get surgeries will be tested for COVID-19 prior to surgery to make sure that they're, COVID-19 negative. We're now good at knowing that if they do test positive, we wait for 10 days to make sure that they're asymptomatic before they go back to surgery. So what I would say that we're now gotten, now we're back up and running. And in June, they began letting researchers go back in shifts. And then in September, now we're not even at shift work. We're just, we can just go in regular hours.
I see.
But still, like, we get checked at the door with our temperature. We get asked questions, how are we feeling that day? And then we get a fresh surgical mask every day.
Okay, so the changes because of COVID were just for you personally, like getting your temperature checked at the door.
Yeah.
It did not change your research. You weren't forced to change gears from kidney to COVID then.
No, we weren't. I mean, we're really not. I don't think we don't have that many faculty that study viruses per se at MD Anderson. I know at Baylor, Methodist, I knew people that had switched over to do more COVID-19 testing, more COVID-19 research, but we're really just focused on oncology.
Yes, well, we appreciate having people like you doing the research, and hopefully cancer can be eradicated in our lifetime. It's been wonderful talking to you this morning. Thank you for joining us.
Oh, thank you for inviting me.
Goodbye to your parents.
Bye, Niki.
Thank you, and we're going to be starting